Hi, everyone. As Lauren said it, I'm currently one of the MFM fellows at Emory, and my goal today is to discuss with you, kind of in broad strokes, hypertensive disorders in pregnancy, their diagnosis, their surveillance, and their management. The objectives for this course are really just to go through exactly what I said, diagnosing, reviewing the various hypertensive disorders in pregnancy, and discussion of how to the extent that we can, prevent the morbidity associated with this disease. And I'll talk to you from an MFM perspective how we survey these pregnancies and our recommendations for surveillance and delivery. Next slide. So currently we know that chronic hypertension complicates about 10% of pregnancies, and that number is rising with kind of increasing age and obesity of our population, and that this increases your risk of adverse outcomes about 13-fold. Hypertensive disorders of pregnancy, which are gestational hypertension and preeclampsia, currently affects about 5 to 7% of births, and that also is rising, again, because of increasing rates of chronic hypertension and obesity. Next slide. This matters because, as we know, maternal mortality is rising throughout the United States, and nowhere are we more sensitive to this than in our state of Georgia, where currently we rank about among the highest in terms of maternal deaths per live birth. Next slide. And when we did a review of these causes of death, we found that cardiovascular conditions are the leading cause of preventable pregnancy-related deaths in the state of Georgia. Next slide. The Maternal Mortality Review Committee functions to review the pregnancy-related and associated deaths, and amongst these cardiovascular deaths, they found that 28 to 50% of these deaths were preventable. And what we're seeing is that the reasons why women are dying related to cardiovascular disease are because of various health system and patient and healthcare provider failures in terms of recognition, timely diagnosis, and timely treatment. Next slide. Specifically, what I'm talking about when I say cardiovascular diseases are these hypertensive disorders. So chronic hypertension can be diagnosed in a woman who presents with elevated blood pressures prior to 20 weeks, or if review of her medical chart allows, demonstration of blood pressures higher than 140/90 at some time outside of pregnancy and at least 2 occasions. In comparison, the other disorders are classified or diagnosed during pregnancy. Gestational hypertension is kind of the most benign etiology, blood pressures that are 140/90, but without any proteinuria or other symptoms. And then the preeclampsia spectrum is the association of elevated blood pressures with proteinuria or systemic signs or symptoms. Superimposed preeclampsia is when you develop preeclampsia on top of chronic hypertension. Next slide. And when you look at the preeclampsia spectrum, we categorize this into mild preeclampsia with severe features, previously known as mild preeclampsia, or preeclampsia with, with severe features or severe preeclampsia, and without severe features, previously known as mild. And the features we look for are blood pressures that are in the severe range, or 160/110, thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, new cerebral or visual disturbances, and eclampsia features. Hello?
I'm sorry, Dr. Joseph. Somebody have their phone on hold. Would you just mind checking if your phone is on hold? Because that's where we're getting the background music from.
Next slide.
Thank you.
And the question is, why does pregnancy cause such a poor contribution of cardiovascular disease to maternal health outcomes? And it's really that pregnancy is considered a cardiac stress test in itself. Normal adaptation to pregnancy, which is characterized by increasing blood volume in order to provide adequate supply to the fetus and uterus, means that there's increased cardiac demand, increased heart rate, increased stroke volume, et cetera. And those women that are more susceptible to cardiovascular disease will ultimately have poor outcomes because of higher risk of heart attacks and heart failure because of their inability to compensate for those cardiac changes in pregnancy. Next slide. Specifically, the risks that we worry about are higher risk of preeclampsia, renal failure, stroke, pulmonary edema, and then maternal mortality, as we discussed. And then from an obstetric and neonatal perspective, there are risks too: abruption, preterm birth, growth restriction, perinatal death. And so, next slide, what we do for these women when we see them is we try to, one, predict any woman, all women, chronic hypertension or not, what their risk is of having preeclampsia, mitigating those risks, performing baseline organ damage assessment, initiating aspirin for those that meet criteria, and other interventions as necessary. And again, when we see these women, we think about what their underlying risk factors are for preeclampsia. Traditionally, this has been historically based on nulliparity, age over 40, prior history of preeclampsia, multifetal gestation, pre-existing diabetes, or underlying chronic disease, such as antiphospholipid syndrome, lupus, or renal disease. But of these women that are at high risk for preeclampsia, the women that really we're seeing that are high risk of cardiovascular mortality, next slide, are those women that are Black, that are over the age of 40, that have baseline hypertension, or that have a pre-pregnancy BMI of over 35 or obese. Next slide. So our initial evaluation is that we look at baseline target organ damage. So this includes cardiac evaluation, including assessment of maternal systems. The New York Heart Association classification assesses women based on severity of symptoms, ranging from no symptoms to difficulty going up a flight of stairs. Cardiac evaluation can include an EKG for someone that you suspect doesn't have much disease to an echocardiogram. Liver function tests and platelet tests can be obtained as a reference should the patient develop symptoms that are concerning. Then you know what you're starting with, especially in those women that are obese, as they can have fatty liver and have elevations of their LFTs at baseline. And then finally, we like to look at the renal function with a baseline serum creatinine as well as a urine protein assessment, as this has both a reference value but also prognostic value, which I'll go into. Always remember that consider secondary hypertension in those women that have either hypertension that's really resistant to treatment, hypokalemia, strong family history, or severe end-organ renal disease, as that might be associated with a Fanconi's anemia or an Addison's disease or something else that you don't want to miss. Next slide. So as I was saying before, baseline renal function can be a prognostic indicator, and this is a study that was done by Cooper in 2016, in which the first column looks at the outcomes. The next two columns look at creatinine less than 0.75 compared to creatinine over 0.75, and what they showed all the way in the last column was that a creatinine higher than 0.75 was significantly associated with developing severe preeclampsia prior to 34 weeks, the development of severe preeclampsia at any gestational age, as well as just preeclampsia at any gestational age. So having that baseline urine can tell you what the woman's chances are of developing preeclampsia and whether or not it will be severe, and the chances of developing that severe preeclampsia at a preterm delivery, which kind of informs your testing. Next slide. Unfortunately, these risk factors that I discussed previously only capture about 30% of women who will develop preeclampsia. We know these labs and et cetera have really failed to predict women at high risk of developing preeclampsia, but there are some investigational approaches that I'll briefly review. One is looking at angiogenic markers. I think a lot of us have heard of like SFLT1, an angiogenic marker that's elevated in women with preeclampsia but has very low sensitivity and very high false positive rates. Investigation or interrogation by Doppler of the uterine arteries has also been suggested. But there are no established kind of normative standards by gestational age, and also no standards for the technique for performing this investigation, so that has not been broadly recommended. And then finally, risk prediction models, which I offered the website here, but essentially it's a website that you put in the woman's gestational age, historical risk, and some of these biochemical parameters that I discussed, and that can give you a risk stratification, but this is purely investigational. Next slide. We wish we could see women before they were pregnant and advise them, to get their pre-pregnancy BMI at goal, to optimize their glycemic control. But ultimately, we're seeing these women in pregnancy, and the only intervention we have is aspirin prophylaxis. Next slide. And so there have been a lot of studies looking at the role of aspirin prophylaxis at various doses and the timing during pregnancy. And ultimately, systematic reviews have concluded that there may be some benefit. There probably is a benefit to aspirin prophylaxis during pregnancy, including this New England Journal of Medicine article that was most recently, the most recent kind of paper on this debate, and that showed that it was associated with a reduced risk of preeclampsia prior to 36 weeks. Next slide. Such that SMFM updated their recommendations last year to recommend aspirin prophylaxis for women deemed at high risk. So those women who've had a history of preeclampsia, twins or more, chronic hypertension, diabetes preceding their pregnancy, renal disease, and autoimmune diseases. These women should have aspirin initiated after 11 weeks, although any time in the pregnancy, ideally prior to 16 weeks. And then there are moderate risk factors where you can consider. Overall, we consider this, a very low risk medication. There have been no associated adverse neonatal or fetal effects. And the only really contraindication is for women who have known aspirin hypersensitivity or evidence of GI bleed. The next slide. The other thing is whether or not we treat women with blood pressure medications, and the jury is still out, and in fact there is an ongoing trial investigating whether or not antihypertensive therapy is associated with improved maternal and fetal outcomes. For now, we've seen that there's really a lack of data showing any maternal or perinatal benefit, and there are some concerns regarding risk in terms of fetuses that are exposed are small for gestational age. So currently our recommendation is just to treat if women have severe hypertension, so blood pressure higher than 160/105, or if there's evidence of end organ damage, such as a woman that's had a prior heart attack or a prior stroke, or you're seeing the renal function is really elevated. Those are the women that you might want to treat. Next slide. And again, this just goes through the most recent randomized trial that showed that hypertension management for women who did not have severe range blood pressures was associated with higher risk of small for gestational age, but no difference in maternal complications like stroke or pulmonary edema or renal failure, and no difference in rates of pregnancy loss or ICU admission. So if you're treating these women, the target blood pressure is usually around 130s to 140s, over 80s to 90s. But if women have persistently mild range blood pressures, you can either encourage them to enroll in the ongoing randomized trial or just follow them. And then the current medications that we use during pregnancy, which I won't go into in too much detail, but labetalol, next slide, labetalol, nifedipine, and methyl-dopa are the medications that kind of have the best efficacy and the best data in terms of neonatal safety and maternal safety in pregnancy. Next slide. So when we see them in MFM, the goal is to survey them for development of superimposed preeclampsia. These are women who have baseline chronic hypertension, and then women in general who don't have hypertension but have risk factors for the development of preeclampsia. Monitoring fetal well-being and discussion of timing of delivery. Next slide. We know that women who have chronic hypertension and develop superimposed preeclampsia do have a worse prognosis than if they had either condition alone. But the diagnosis is really hard. The textbooks will say that this tests the skills of the clinician because women who have chronic hypertension, we know because of pregnancy physiology, they can develop just elevated blood pressures as they start to, adjust to their pregnancy. That may not be superimposed preeclampsia, or it may, and they may develop new or worsening proteinuria. Certainly any new organ involvement would assist you in making that diagnosis. Next slide. But we always ask for symptoms: headache, tinnitus, dizziness, scotomata, nausea, vomiting, epigastric pain, blood pressures that are higher over 140/90, on at least 2 occasions and accurately measured, warrant investigation. Proteinuria, and we use a P to C ratio of over 0.3 milligrams per deciliter or over 300 milligrams in 24 hours. And again, proteinuria can be present or absent, but hypertension in conjunction with either symptoms or laboratory findings of thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, cerebral symptoms, that would be concerning for preeclampsia as well. So again, proteinuria does not need to be present to make this diagnosis. And this is just a word on accurate blood pressure measurement, which we see a lot. We know that hand measurement is the best, and we want the woman to come in sitting, semi-reclined, back-supported, arm at heart level, and that she's had the chance to sit for 5 minutes. That often rarely happens, but for elevated blood pressures, a recheck using the standards makes sense. Next slide. As far as fetal assessment, we know that pregnancies that are complicated by chronic hypertension have a 2 to 3-fold increased risk of stillbirth and higher chances of growth restriction. So ACOG recommends some form of fetal testing. In our practice, we do once or twice weekly testing after 28 to 32 weeks, depending on the severity of her disease. And then in regards to timing of delivery, data have shown that delivery at 36 weeks, there's a higher chance of perinatal morbidity. After 39 weeks, maternal morbidity with regard to higher onset preeclampsia. So the recommendation now is somewhere between 37 to 39 weeks, and for us, we recommend 38 to 39 weeks, depending on the severity of her disease. The antepartum management for women for preeclampsia, I summarized here in a few graphics. The first one is looking for, so if a woman comes in with elevated blood pressures, proteinuria, maybe some target organ damage, the first thing is to assess for absolute contraindications for expectant management. This means delivery even before they've gotten antenatal steroids. So that would be if the woman's eclamptic, if the pregnancy is non-viable, or there's a stillbirth, if there's evidence of a severe abruption, pulmonary edema, the testing is not reassuring, she's in DIC, or the hypertension is just difficult to control. If that's present, then yes, you will move towards delivery. If not, next slide. Thank you. If not, you will assess for severe features. The severe features are systolic blood pressures higher than 160 over 110, headache, vision changes, epigastric pain, abnormal LFTs, platelets less than 100,000, creatinine higher than 1.1, and AST, ALT that are higher than twice the upper limit of your lab's reference standard. So assuming that that's not present, then we would say she does not have severe features, and our goal is ultimately delivery at 37 weeks. Next slide. However, if she's between 34 to 37 weeks, you would give her antenatal steroids, depending on your institution's protocol for late preterm steroids, and then assess for indications for delivery after steroid complete, and that would be severe IUTR, oligohydramnios, or evidence of labor or non-reassuring testing. If that's present, then again, delivery. If it's not present, you consider inpatient or outpatient management with delivery at 37 weeks, sooner if any of those concerning signs develop. Next slide. And if she's under 34 weeks or prior to 34 weeks, certainly the recommendations, strong recommendation for antenatal steroids, and then assessing the same indications for delivery, primarily non-reassuring testing. And again, if that's present, delivery. If not, again, expected management at 37 weeks. Next slide. Hello? Okay. However, going back to, again, assessing absolute contraindications for expected management. Again, we said if no, assess for those severe features. Sorry, next slide. And then this is if, and then next slide, this is in the presence of severe features. So you're seeing severe range high blood pressure, headache, vision changes, epigastric pain, etc. So over 37 weeks, magnesium prophylaxis and delivery is the recommendation. Next slide. Between 34 to 37 weeks, antenatal corticosteroids and delivery. So for patients who have preeclampsia with severe features, after 34 weeks, the recommendation is for delivery with magnesium prophylaxis. Where it gets tricky is under 34 weeks. So next slide. And for these patients, certainly they are admitted to the hospital for inpatient monitoring. And our goal is, expected management until 34 weeks. Antenatal steroids are recommended. However, on a daily basis, you're assessing to see if the patient's developing HELLP syndrome, oligohydramnios, non-reassuring testing, etc., at which point you would deliver independent of gestational age. Otherwise, the goal is delivery by 34 weeks. Next slide. And I know this is all confusing. Luckily, ACOG has an app. It's like there's an app for that. Their indicated delivery algorithm is here on the first panel. On the next panel, you input the gestational age, and you can add a condition. Next slide. And then you can see, okay, for this patient who's 31 weeks who has chronic hypertension that's, uncomplicated, well-controlled, they'll say deliver at 37, 39 weeks. But you can put in different parameters for your patient, and then they can offer you recommendations on when to deliver. But I should note, maternal fetal medicine consultation is always advised, and we're always happy to even talk by phone about any patient. Next slide. So intrapartum management, again, for those women who have severe features, the recommendation is for routine parenteral magnesium sulfate for seizure prophylaxis, IV antihypertensives intrapartum for those women that have severe hypertension as well, and then delivery. We say that a cesarean should be reserved for the usual obstetric indications, with the caveat being that if you're at 24 to 28 weeks and you're being induced for preeclampsia, the success rate is only about 39%. So in that setting, you may consider moving forward with cesarean section rather than attempting an induction, but certainly it's depending on patient stability. Next slide. I think what's getting more recognition, and certainly our work with the Maternal Mortality Review Committee has demonstrated that a lot of women are developing postpartum complications as well as new onset postpartum preeclampsia. So we know that 75% of deaths secondary to hypertensive disorders occur actually after birth, with the majority occurring 48 hours after delivery. And a lot of these women are actually not even diagnosed as having a hypertensive disorder during their pregnancy. Unfortunately, these women, they're delivered, so they're presenting to emergency departments or their primary care doctors and providers that don't have a high index of suspicion for pregnancy-related complication. And so, the onus is on us to kind of help teach these providers about the risk of postpartum preeclampsia and appropriate management strategies. Next slide. So these include a patient who's less than 6 weeks, or essentially the trigger is a patient who's less than 6 weeks from delivery who's presenting with severe blood pressures or blood pressure 140/90 but has unremitting headache or visual disturbance or epigastric pain, that they should be initiating antihypertensive therapy. And there's a new kind of indicator looking at from door to treatment, so that within an hour of their most severe range blood pressure, their most recent severe range blood pressure, they're getting medical treatment, getting blood pressure medication to reduce those blood pressures, as well as appropriate consultation with their primary OB, MFM, critical care as indicated. And then typically, these women can be observed or admitted until they've demonstrated adequate control on an oral regimen. Next slide. All patients, when we're sending them home, independent of whether or not they have preeclampsia, they should have information about the warning signs for preeclampsia, and as well as information on how to contact their provider or whom to call if they develop these symptoms or signs. And then those women who do have preeclampsia, we recommend, and ACOG recommends, that they have a blood pressure check within 72 hours from delivery. This can be either an office nurse check or a visiting nurse that goes home and can check the patient's blood pressure, and they should be seen by their provider within 7 days after discharge. Next slide. And then the last bit I wanted to touch on is, the implications for future cardiovascular health. I think amongst us, we know, and it's increasing recognition, that preeclampsia in a pregnancy is an established risk factor for long-term cardiovascular health, and that half of these patients will go on to develop chronic hypertension if they didn't already within 2 to 5 years, and then further on that they're at a higher chance of having adverse cardiac events such as heart attacks, renal failure, and strokes. As yet, the current risk calculators, such as Framingham, have not updated their risk stratification on the basis of a pregnancy complicated by preeclampsia, but current societies are recommending annual screening of blood pressures, lipids, and fasting glucose for those women that have endorsed this prior history. This is an ongoing area of research, and so we'll know more about kind of how we take care of these women and their long-term health moving forward. So I'd like to conclude by saying, first of all, thank you for your attention, and just highlighting that the prevalence of these of hypertensive disorders in pregnancy is increasing as our population ages and gets sicker, more obese. That for us in the state of Georgia, and that this is the leading cause of preventable maternal morbidity and mortality, and so it requires heightened index of suspicion, appropriate early intervention, surveillance, diagnosis, and delivery when indicated, and that these patients should be aware that they are at lifetime risk for adverse cardiovascular outcomes and undergo annual screening with their primary providers. Thank you so much.